Radium-223 is probably one of the hardest medicines for us to pinpoint the exact right time to use in a patient. The population is diverse. Some patients do have bone-only metastatic disease. Some have a mix. Some bone disease is oligometastatic with only a few large, big lesions. Others might be small, diffuse lesions. We have patients who have bone metastases that are 20 to 40 in number. We may have patients with bone metastases that are 2 to 5 in number. None of these things are sort of a perfect sort of single case for using radium. They're all justifiable, particularly if they're associated with even subtle symptoms. And to me, I think probably the key is the subtle symptoms. It's clear when patients have moderate to severe symptoms associated with their disease, with their bone burden disease, that radium is a good choice. It's just that by the time that happens, these patients are late in life. There have been some really older studies to show that by the time patients develop even moderate degrees of pain associated with prostate cancer, their median survivals are 6 to 10 months. So if we're starting radium in that setting, we're too late. It takes 5 months to get this treatment into these patients. It's too late for that population to see a survival benefit. We really need to be thinking about using this therapy when patients have 1 to 2 years to live or more. So to do that, we need to be thinking not treating sort of moderate degrees of pain, but really treating patients early on for either minimal pain or other associated symptoms with that metastatic disease that puts them at risk for these bony complications like pain or fractures or whatnot. So that's a really critical part to thinking about when's the optimal time. And layering, being able to use this drug sort of on top of drugs like enzalutamide really allows us to begin to think about that in some of these earlier disease settings. It's not the only use. I use a lot of radium by itself off of hormonal therapies because it can be very effective on that bone environment and because in many cases the benefits associated with those hormonal therapies have largely already passed. So to me, this is an agent where we can kind of use it either way. I'm not sure either one is optimal. It just depends on that patient's circumstances, their PSA progression, and their symptoms. But that's the population I want to be thinking about using radium in, primarily while those symptoms are really early in their evolution. To me, the goal with Radium-223 is 6 doses of treatment. And why is that? Because we saw the greatest survival benefit associated with patients that got 6 doses. Remember, in the Alsimca study where that survival benefit was seen, the majority of these patients were performance status 0 to 1. 0. I mean, those are patients that are essentially, normal functioning patients. So we're not talking about patients performance status 2. It's too late for the most part. Thinking about this in good performance status patients is critical so that we can treat patients for a total of 6 doses. That's the benefit associated with this. It's not any one dose that's really benefiting patients. It's the complete course. Similar to chemotherapy. I mean, if we're going to give chemotherapy, we're not going to do it for 2 or 3 doses and see a survival benefit. It's got to go at least 6 doses. Could we go longer with radium? I think it's an open question, but right now, that's not how we're using the drug. That's not what our data speaks to. It might in the future. But I know that at least 6 cycles is what I really want to shoot for with these patients. Many of them get the end of that and are still doing well. I'm okay stopping there because I know that the survival benefit was associated with 6 cycles. So I don't try to go beyond that with my patients, but I do try to get there. And I think for patients, it's really helpful for them to know there's a stopping point. We're not going to do this indefinitely. We're going to do this for 6 doses, 5 months. We're going to reevaluate and go from there.